And the contractions were coming so fast now that those are the things that the doctor must talk over. I hope I haven't stressed it too hard, friends. It's because I want to make sure that you have 100% success with what you have seen tonight. Now, many of you must have questions about the coma. But before we go into that, let's go back to this hypnoanalysis thing. How many are going to bring patients for this hypnoanalysis session? 1, 2, how many more? 3? Huh.
Are these patients that have...
Neurotic problem cases. Stutterings. Ladies and gentlemen, I want you to meet the one doctor in all medicine who doesn't have no... Oh, I see. All right. But I still have to meet the first doctor in the world who doesn't have neurotic patients. Now, what I want are patients with migraine headaches, for example. Patients with unexplainable aches and pains, where you can find no organic pathology. The very patients that your husband can't find a reason for their aches or pains, those are the ones. Now, I've got to know that we're going to have about 10 or 15 such cases, because sometimes you'll work with a patient and you'll get a rejection, and if you get that rejection, you've got to go on to the next patient. So let's see how many we can have. How many will you bring, doctor? Well, you'll be in the Oklahoma City class anyhow. How many will you bring? One. And then 1. That's only 2. You won't have...
All right,
3. All right, 5 or 6. That'll be about 8. Look, don't leave it to anybody else. Bring your own neurotic patients, because sometimes you're going to be amazed at the instantaneous relief those people get, which lasts forever. I'm not promising any magic cures. This is not a cure-all. This is not a panacea. I'm just saying they will get vast relief, tremendous relief, in many cases that will last for a long time. I don't think one session with hypnoanalysis will ever cure anybody, but it will do them a lot of good. Let's take the questions on the coma, because I know that many of you, having seen this, want to ask questions about it. So if questions occur to anybody, let's have the questions. Yes, doctor?
How come they all didn't get
The catatonia? Everybody gets it. Now, let me tell you what kept a terrific number tonight from getting it. One of the patients went so deep, and then she got into a very uncomfortable position because she sagged like that, and I had to call up her doctor to get her into position right, because she just opened her eyes and they were a complete blank, just like they do at delivery time. They are just so relaxed that while those eyes are opened, they apparently are seeing nothing. Who was that patient? Is she here now? The one that did that? She's downstairs. Now, the doctor came up and altered her position, but that worried the other women. That is, some of them at least. And so they didn't get it. You would have seen probably about, 10 or 15 more women getting catatonia had that not occurred. I may say this, and you can verify this from any old student who's used the coma, that when you have the perfect coma, the catatonia always appears. Is that right, Dr. Meese? Is that correct have you found that to be so? And there's several others here. Well, you gentlemen over there, is that correct? Right. In other words, don't worry about it if it doesn't show up. Why, woman after woman there who had the automatic anesthesia would have her baby anyhow without feeling a thing. But to get the perfect coma, 100%, the catatonia must appear, and it will appear. If there are no worries or anything, it will appear. It shows you what a little thing like fear can do to destroy the state. It's a nebulous state. You can't put your finger on it, and a little fear like that would keep them from going deep enough to get the catatonic feature of the coma. And yet a lot of them got it just the same. Any other questions? Yes, doctor?
How do we handle the other problems associated with
Oh, Doctor, that's so simple. Here's what you do. How to handle other problems involved. Suppose you want to bring them out of the coma so that they can attend to their natural functions and so on. All you have to do, they take suggestions better in the coma than in any other state. That is, mental suggestions like anesthesia. You can tell them, you'll be able to hold on to the anesthesia, but you can come up a flight and open your eyes and tend to your natural duties, and whatever you have to do to attend to yourself, if you have to eat or anything like that, you can do it. Then come back. You'll be holding on to that anesthesia all the time. Then the instant you get back into bed again, you'll go right down into the basement of relaxation again. Suppose you want to get them from the bed to the cart, to the table. You do it by just saying, now, look, we're all ready to take you down to the delivery room, so we want you to get on the cart. Come up a flight, just one flight, hold on to that anesthesia, but come up a flight so that you can help us get you onto the cart. Once on the cart, I want you to let yourself down fully into the basement again, and then when we get you to the delivery room and we're putting you into the stirrups and so on, we want you to come up a flight so that you can help us. But hold on to the anesthesia while you do, and then once you're in position for delivery on the table, then let yourself down and stay that way all the way until the baby is born, and then you can open your eyes instantly and see your baby. And you'll find you'll get complete cooperation. And ask any of the men who have delivered in the coma state, and they'll tell you that that's what happens. It is the most beautiful delivery in the world, Doctor. You've got to see it to believe it.
Do you suggest constant attendance?
No. Why do you have to have constant?
This can be outlined the 4 hours or 6 hours ahead of time. All these.
Well, you're going to find, Doctor, that if you give her proper instructions before she gets to the hospital, that most of these things are taken care of automatically.
So
and if you
when she needs the bedpan, she will
come up a flight, but hold on to the anesthesia. Be sure you tell her to do that. And tell her that she can hold on to the anesthesia. She can come up a flight and she won't feel things any more a flight up than she does now. And that'll do it. You've had to do that, haven't you, Doctor? You had to do it? You've had...
The girls now that are in the states, that you call labor, and walking around the hall. They don't want to stay in the bed now.
Well, that's all right. They can...
Anticipate all these various and some...
Yes, you can say... Doctor, let me tell you, those girls who are walking the floor are fighting their contractions. You won't have too many walking the floor.
Some are just killing time.
Yes, Doctor, but let me tell you what happens really in the coma state. Delivery is so rapid that you don't have those 18-hour and 36-hour and 72-hour cases very often in the coma. You'll have a primipara deliver in maybe 3-4 hours, and it'll astound you sometimes that the primipara will get to the hospital and in an hour she'll have her baby. Because not fighting the contractions, they go a lot faster. Now, those of you who have done deliveries, how much have you found it speeded up, Doctor? How much have you found it speeded up?
More than one.
About how much would you say?
At least knocks off a third of the time, I think. Maybe more.
The third of the time. Now, a third of the time, when you're thinking of 18 hours, it gets it down to 12. But when you're thinking in terms of 12 hours, it gets it down to 8 and so on. Who else has done deliveries in the coma state here? You have. Well, Doctor, how's it worked out for you?
Well, I think the longest has been 4 hours.
The longest delivery that he's had in the coma state has been 4 hours.
One time
Went 4 hours. So you... I beg pardon?
There were 2 long tips.
Mm-hmm. You'll find many times that it's going to amaze you how fast they deliver. They haven't got time to walk the halls, Doctor. That's actually the case.
I have one other question. How about the husband? It varies in different hospitals, but in ours, the husband is allowed in the labor room. Any special instructions to him?
Yes, keep his mouth shut. In fact, it's so very important, particularly if he's not here tonight. If he's here tonight and has seen this, he'll know what to do to tell his wife. He'll say, look, go down into the basement. Stay in that basement so you don't feel anything. And if there's a nice relationship there, they'll do it. Above all, if there's ambivalence there, the husband should not be present in the labor room. Now, any psychiatrist in the world will agree with that statement, because the woman, if there's bitterness there, she won't be able to do as well when he's present. On the other hand, if there's a great deal of love present, he can help a lot. If he's also here tonight and understands what he has to do. But if he doesn't understand what he has to do, I can almost imagine him destroying the state by constantly saying to his wife, "Are you having any pain, dearie? Are you having pain? Are you having pain?" Until finally he'll break through the coma and he'll destroy things. I'd rather not have him there myself, unless he understands. Any other questions at this point? Sure, there's no questions on a thing as important as this state? Are you ready to see the movie now? Oh, yes, give that stuff out, and then anybody who cares to leave early may.
In 10 seconds, again, give us the test that you want us to use.
It is imperative that you make the tests in the order given in the outline. Oh, you can get such a bad result if you don't make the tests in the order given. For instance, doctors not understanding the coma will make a test for the catatonia first. Catatonia doesn't mean anything. Catatonia won't help a woman have a baby painlessly. That catatonia can be gotten in the lightest state of hypnosis. It only means something when it is preceded by the other 4 signs, which seems to compound it to the point where the catatonia occurs automatically. First you say to the woman, "What floor are you at? What floor are you on?" And if she tries to say and can't make the words come out, you know that she is ready for the first test, which is your anesthesia test. After the anesthesia test, then you try to see that they are so relaxed that even when they try, they can't make a big muscle move. I'm meaning by that an arm or a leg. Try to move your right arm. Try to raise your right arm or your left arm or your left leg or your right leg. Doesn't matter, but take a big group of muscles. Sometimes you'll see them move them about an inch. That means that's fine. That's fine. If they can only do that, they're plenty relaxed. If they can move that big muscle any considerable degree, it means they've got to go down another floor. Let them go down another floor. The third test that you make is the small group of muscles, such as the eye muscles. Now, the eye muscles, when they try to open their eyes in the coma, gentlemen, it's an entirely different reaction, or a completely different thing than when you're trying to get them to open their eyes in hypnosis, or trying to make an eye test in hypnosis. Because when you're testing for relaxation of the eyes at the start of hypnosis, you'll see the patient go like this, and you'll see the muscles working. But when they try to open their eyes in the coma, they can't even make the little muscles work that go like that. And this you must see, and you saw it plenty tonight. The fourth test always occurs if the other 3 have occurred. That is, the fourth test is catatonia. Wait a little while for catatonia. It may take an hour for catatonia to develop on certain people. On others, it will develop instantaneously. Don't worry if it isn't there. If you've got 3/4 of it, gentlemen, the 4th sign appears. And the funny thing is, when it does appear, you will be so thrilled by it, because you'll know that this is the perfect state. This is it. Now, they don't know what catatonia is, because that's one thing that can't be imitated, can't be aped, can't be pretended. They can see catatonia on another person, and they won't obtain it if they try to do it. You've got to feel that waxy-like quality, that waxen-like quality. Gentlemen, when that's present, you know you're going to have a perfect result. So that's why I say make all 4 tests. I think it is very important for you to know, too, that delivery is not the only phase of medicine in which the coma is valuable. Dr. Solomon in New York City, not in New York City, in Chicago, Dr. Solomon did a radical breast resection using the coma state for his only anesthesia. Dr. Sullivan of Rockford, Illinois, did a complete hysterectomy. Dr. Alexander of Mount Vernon, Illinois. Gee, I've heard his name mentioned in Oklahoma City. I've heard it mentioned, I think, by somebody. Was there somebody in this class who mentioned him to me? Anybody here mentioned Dr. Alexander to me? We've had classes so far away from that man, and yet doctors have been talking about the wonder workings that he's been doing. We could give you the names of man after man after man who has done very deep, intensive work. Now, when it comes to intractable pain, and I think this is something we must cover completely, this is the state in which you get rid of intractable pain, and it stays away. Now, I would like to, at this point, if I may take a few minutes additional, show you my technique for getting rid of intractable pain. I understand that Dr. Tinnerow of your city here has done a lot of work with intractable pain. In fact, that's what he was talking about at the convention of surgeons which hit the AP wires. But I still feel that perhaps you ought to know how I do it, because I have had remarkable success with intractable pain. You men have had to invent your own methods, the old students, because I've never thought it necessary to do this before. But when I see a man able to get the coma on a carcinoma victim, for example, and then he doesn't get relief of pain, then I say to myself, wait a minute, what in the world is the matter with his semantics? Now, may I have some woman on whom we work so that I can reproduce the coma instantly, and I'll treat that woman as though she's an intractable pain patient, and I'll show you how I would get rid of that ache or pain. Anybody who wants to be my subject for me? Any of you ladies that I worked with tonight? My God, you like the state so much. Come on up. Just turn the chair around the other way. Doctor, so that I don't have to get up.
Are you too full, brother?
No.
All right. Now, first you must know that intractable pain is handled this way. Now, I would be talking to the patient, and I would be saying something like this. You know, it's an odd thing. I know how sick you've been the past few months, and I know you've had a lot of discomfort. But I wonder if you realize how much more discomfort you've had than you really have to have. Did you ever realize that there's a lot more discomfort in you at the present time than has to be there? And he looks at you, or she looks at you, what do you mean? I know, I hurt. I know, and I'm not denying that you hurt. I'm not saying you don't hurt. I'm not saying you don't have pain. But let me tell you some of the fundamentals of pain, and then you'll understand why you're feeling things more than you have to feel them. You know, when you have a little pain, what do? You tense up, don't you? And then what happens? Because you tense up, you feel the pain all the more. And then because you feel the pain all the more, you tense up some more. And it becomes a vicious cycle. And if this keeps up day after day, week after week, month after month, finally you are feeling that pain and that hurt, oh, so much more than you have to feel it. Now let me show you how we can just unwind, get rid of some of that tension, and let you feel how little you feel when you feel it at an ordinary level. Would you like to do that? And the patient generally says, oh, if you could help me, Mr. Ellman. All right. Your doctor has brought me here for that purpose, and I can help you if you will let me help you. Now, the first thing I'm going to ask you to do is just Get comfortable in your bed, just as comfortable as you can. Now close your eyes. And they take these instructions, will you please? Now close your eyes. Now relax the muscles around your eyes to the point where those eye muscles won't work. And when you're sure those eye muscles won't work, test them and make sure they won't work. That's right. Now let that feeling that you have in the eye muscles go all the way down to your toes. Just cover yourself with a blanket of relaxation. Now we're going to do this in a minute more. I'm going to have you, when I tell you to and not before, open and close your eyes, and you're going to be able to increase this relaxation many times over. Now open your eyes. Now close your eyes. Notice how good you start feeling, just because you've got this amount of relaxation. Now we can even double what the relaxation you've got now. So open your eyes. Now close them again. And now let yourself completely relax. Now this is good physical relaxation. But imagine what those tensions must have done to your mind. Imagine how tense your mind is. I want to see if I can't unlax that mind. Just relax it to the point where you're just as relaxed mentally as you are physically. And I'll tell you how we'll do that. We'll start counting from 100, and each time you say a number, double your relaxation. By the time you get down to 98, you'll be so relaxed mentally, you won't be able to think of numbers, you won't be able to see numbers, the numbers just won't be there. And make that happen, just dispel those numbers. Now, start counting out loud, please. Now, double your relaxation, watch the numbers disappear. That's right, now watch them go. Gone completely, aren't they? That's right. Now, notice how good you feel when this mental and physical relaxation together take hold. And just let it take hold, and with every breath you take, now, that relaxation is going to become more intense. Now, you know that this is good relaxation mentally and physically. And you can already see how much better you feel. But you know there's a stage of relaxation below the one which you now have, the very basement of relaxation. And I'd like to take you right down to the basement. I want you to see how good you feel right there in that basement of relaxation. Tell you how we're going to start out for that basement. I want you to know, just like you can make a fist tense so that you can't make it any tighter, you can also make a muscle loose so that you can't make it any looser. And I want you to make every muscle in your body loose like that, so that relaxation is through every muscle in your body. Then notice how little you feel things. So we're going to start down to the basement of relaxation, and I'll know when you get there because you'll give off the signs. One of the signs you'll give off, incidentally, is a sign that you'll recognize it when you feel it. So the first thing I'm going to do is to ask you to just imagine yourself on your own elevator or escalator, whichever you prefer. And we're going to ride down to the first floor now. That would be floor A. We're heading towards the basement of relaxation. When we hit C, that'll be the actual basement. Now, in order to get to A, you have to double the present relaxation. In order to get to B, you have to double the relaxation that you have at A. And to get to C, you have to double the relaxation that you have at B. But when you're at the basement of relaxation, you'll know it by the way you feel. Now, I'm going to count to 3, snap my fingers, and imagine yourself on this escalator or elevator riding down to floor A, and let yourself relax as you go, and say the letter A out loud when you reach floor A. 1, 2, 3, here we go. Now say the letter A when you feel yourself twice as relaxed as when we started that elevator or escalator going. That's it. Now, we can go down to floor B from here. You've got to double your relaxation, and notice how much better you feel on each lower floor. Now, I'm going to count to 3, snap my fingers, and we'll be on the way to floor B. Watch. 1, 2, 3. Here we go. Now, if you can't say the letter B out loud, that means that you're relaxing your muscles to the point where they won't work. That's what I want to happen. So if it becomes difficult for you to speak, don't worry about it. But try your darndest to say the letter B when you get there. It's there, it's coming, that's beautiful. Now notice how good you feel as a result of it. Now let's go down to the very basement. Let's double the relaxation again. Take you right down to the basement of relaxation. 1, 2, 3, and here we go. Now here is where your automatic anesthesia comes in, gentlemen. And this is what is so delightful to the victim of intractable pain. This is the technique I use, and this is the technique which I think you should use. Because once that automatic anesthesia comes on, you say to the patient, she's probably at floor C. See if you can tell me what floor you're at. Is she able to say it? No, okay. Well, then she's there. She's ready for test, and what we would ordinarily do now, we would make a test with an Alice clamp or a towel clip or something like that to make sure the automatic anesthesia is there. But she's got it. She's got it. Now, with a carcinoma victim or the arthritic victim or someone with intractable pain, you don't want to cause them anything at all, so you don't make a test at this point. You merely let that automatic anesthesia come on, and you say, now you'll be able to hold on to this. You'll be able to hold on to the way you feel even after I have you open your eyes. And I want you to hold on to this until my next visit. I want you to feel so good, and I want you to see how little you feel anything just by staying relaxed like this. And gentlemen, in most instances, you'll have a perfect result. I'm awfully sorry that I didn't show you men in Wichita this same thing last year, because I think most of you could have been doing work with intractable pain much more successfully than you have been doing it. I understand that in 5 cases, Tinero failed with it. I don't think you should ever fail with it in intractable pain. I think that this is the one thing that is almost a specific for intractable pain, if you know how to go about it. Have you gentlemen worked with intractable pain? Have you, doctor? Has anyone else in the room worked with intractable pain? I mean, well, probably in the present class you have, but I'm talking about the old students now. Well, gentlemen, can you see how you would be successful with this? Can you see how it would work? Having worked with it, or having seen it now, and having worked with the coma for a year or more, can you see how it would work? And now, you know that there comes a time when if you don't open your eyes when the doctor tells you to, you can't have this wonderful state again. So you bring yourself up a flight, you'll be able to make those eye muscles work, and notice how good you feel when you open your eyes. Now, bring yourself up. And eyes all open and everything? Good. How do you feel? Isn't that a wonderful feeling? Okay, thank you so much. All right, now we're going to show the movies if there are no more questions. Gentlemen, does that give you the idea of how intractable pain can be handled? Are there any questions on it? Yes, doctor.
I have a patient I can't get her to let go of the numbers, but she was comfortable and the pain was gone.
Mm-hmm. That's all right.
Only the nasty fractured hip.
Oh.
I'm not unhappy about it.
Right?
I'm not unhappy.
Oh, no, that's a good result.